Welcome, everyone. We are just going to let people settle in. We'll give it about 1 minute. All right. Looks like the participants have stabilized a little bit. If you're anything like me, I know I was just running to make it to the meeting. So we may need to just remind people so that it's starting. So sometimes we send out these texts, but we're going to go ahead and get started. I'm sure people are going to trickle in as we go on. So I just wanted to say a few words, actually, because some of our usual suspects are not attending this meeting. But I wanted to welcome everyone to the inaugural 2022 medical education meeting. Although we have it every month, it's always nice to start a new year. So thank you all for taking the time to attend the meeting, because I know the past weeks have been a little bit crazy with everything going on with COVID. As you all know, we are undergoing a leadership transition. Unfortunately, I know we're all sad by this, but due to health concerns, Richney has transitioned out as the CEO, and Mark has begun his tenure as a CEO of AP Derm, and we're all very excited to welcome Mark. You know, Mark is really deeply invested in getting to know each and every one of the clinicians and getting to know our practices, getting to learn dermatology, and to ensure that we all continue to have success. Unfortunately, this was just really poor timing that both Mark and Rich had an unavoidable conflict right now because of the transition. So they will be unable to attend, but they definitely send their best wishes to everybody. And Mark will absolutely be at the next one in February. So he looks forward to the next meeting. If you guys have any questions, you know, I know his door is wide open, so people can always reach out. I see that Dr. Stitt just sent a message, but I think, yeah, we can address that. The meeting should be open up to everybody. So hopefully everybody should be able to hear us. So just wanted to move on. So I'm very excited for this hair conversation with Dr. Goldberg. So Dr. Lynne Goldberg is an expert, well-known national expert on hair disorders, for her expertise both on the clinical diagnosis as well as the pathology correlations. As you know, she's a dermatologist as well as a dermatopathologist. She's a professor of dermatology and pathology and laboratory medicine at Boston University School of Medicine, and she also directs the hair clinic. She's an avid lecturer and has presented at numerous local and national and international conferences. She certainly trains residents, fellows in dermatology and DermPath. She serves on the board of the American Society of DermPath, as well as on the Journal of Cutaneous Pathology. She's published numerous articles about clinical research regarding hair, and many of us trust her with helping our patients with hair disorders. So please join me in welcoming Dr. Goldberg.
Thank you so much, Dr. Obechi. It's a pleasure to be here. And although I can't see you all, I know that I know a lot of you. So it's great to speak to you today. I'm going to go ahead and share my screen. Let's go screen, share, and great. I think we are good. Yes, can you just confirm that you guys can see me?
Yes, we can definitely see your screen and we can see you.
Great, excellent. Okay, so today's talk I entitled Alopecia CPC, but that's just kind of a little part of it, as you will see. Thank you so much again for the invitation to speak this evening. I'm really excited. It's just too bad I can't literally see everybody. All right, let's go to the next slide. So now the slides are not advancing. Hang on.
By the way, it's a great point. You know, we definitely would love to make this interactive. I think unfortunately the format of the webinar in Zoom doesn't allow us to show the video of the participant. So it ends up being kind of a screen share mostly, but everybody feel free to use the Q&A below as well as the chat to converse with us. But unfortunately, we can't switch the mode of the webinar during the meeting, but I agree with you.
All right. Yeah, we'll have plenty of time for discussion at the end, and maybe we can put on the video then if that works. I don't know. Anyway, the only disclosures I have are that I do receive royalties for writing for Up to Date, but it's not really related to this particular lecture, and I will be discussing off-label use of medications. So why do you need to correlate your biopsy report? Well, the biopsy is just a small sample relative to the scalp, right? And the pathologic changes can be focal in the specimen, so they may not match what you were thinking. There can be more than one process. That happens not uncommonly. Of course, your dermatopathologist has not seen the patient, although these days that's changing with the photographs. We can see a lot of our photos here at BMC, but sometimes the findings are misinterpreted, and it takes a team to figure that out when that happens. So for example, this is a patient that comes to you and you've done a biopsy, and the biopsy reveals lichen planopilaris, and you look and it's kind of a diffuse hair loss. This is a guy. You don't really see the patchy hair loss of lichen planopilaris. Hang on, sorry. So the question is, what happened? This is either a diffuse form of lichen planopilaris or it's something else. Well, there actually are diffuse forms of lichen planopilaris. This was a paper published in 2019. On the left, you can see an entity called fibrosing alopecia and a pattern distribution, which I'll talk about in a minute. And on the right, the authors describe what they thought was diffuse lichen planopilaris. And I do have patients who come complaining of terrible symptoms before I really see any hair loss. And maybe that would explain it. Maybe this won't be diffuse for long. But I'm not sure about this. I don't like their dermatoscopic picture. I'm not sure I buy the diagnosis, but that's a separate issue. So there may be instances where lichen planopilaris can have very little loss at first. Now, what about fibrosing alopecia and a pattern distribution? This was first described in 2000 by Zinkernagel and Trueb, and clinically it looks like AGA, and you look at the patient from the door and you're like, okay, we're going to be going through the Rogaine thing. But when you get in there close, and that's the picture that came up before, you can see that there's some perifollicular scale, and you notice there's a smooth scalp surface. So there's a debate about this chicken and egg thing, like which came first, the androgenetic or the lichen planopilaris. This is a paper that was a review of all cases of fibrosing alopecia and a pattern distribution. And it was interesting that a lot of these patients were not biopsied, like the diagnosis was made clinically. And this is a dermatoscopic picture from that paper. And you can see the arrows pointing to, 3 different patients with perifollicular scale. But this was our patient, right? And there is no perifollicular scale. So I'm not even sure this diffuse LPP fits for our case. And you notice there's a lot of fine hairs in the high-powered view in the trichoscopy picture. So let's look at the biopsy. So on the left is the isthmus level, and I don't expect you guys to know this, but this is what I do all day long. And you see there are sebaceous glands that are together with the hair follicles as follicular units. And when you see follicular units at the isthmus level, you have a non-scarring alopecia right off the bat. So I don't think LPP fits, but now I'm thinking, well, what made it LPP? And if you look on the right, there's the same biopsy, higher level, and you can see to the right, there is some perifollicular inflammation. If you just saw this level without taking into account what was going on below, you might make a diagnosis of LPP. However, we know, and what does our patient have? Our patient probably has, well, our patient does have androgenetic alopecia that was misdiagnosed as LPP because of the superficial inflammation. We know from Dr. David Whiting, who was a great pioneer of transverse sections, and this paper was done back in 1993, that 36% of male pattern hair loss patients had moderate, mild to moderate, or moderate to severe, rather, inflammation around the hair follicle. So the presence of superficial inflammation does not mean you have an inflammatory scarring hair loss. And this is what our patient's biopsy looked like. And you can see it's very, very similar. So our patient had male pattern hair loss with moderate to severe inflammation, misdiagnosed as LPP. Now, the good news is that I'm not going to be talking about cases all night long that were misdiagnosed, blah, blah, blah. So really, these were the topics that I was given for this lecture that you guys had expressed. And they were hormonal workup for AGA, alternative therapies for AGA, including PRP, laser light caps and supplements, and scarring alopecia. So I will give the audience what they want, except for the first one, hormonal workup, because I'm not really sure there is much hormonal workup. I may be talking about this at the upcoming AAD, so I'm going to skip that one for now, but I will discuss the rest of it. And I added a few things that I think will be of interest to the audience, including the use of oral minoxidil and current controversies, which I think is super important. So I just want to tell you, don't give your patients minoxidil and say this may or may not help and leave the room, because all of those patients end up coming to me. So you need to talk to the patients about minoxidil. Those of you who trained with me or alongside me probably know all of this. It's a review, but you have to first decide if they're going to use it forever, because if they're going to give up and they know they're going to give up, then this is not a good medicine for them. The results are not going to double their hair in 3 months. You have to tell them it's pretty subtle. You may not even see a difference, but you should not get worse. I typically use the 5% product. Now this is endless confusion because the women's liquid is a 2% product. So I either tell women to use the men's 5% solution or use the foam, which is 5% for both. So that is very confusing. The bottle says to dry hair, but you can use it after you shampoo. That's a perfect time to use it. Just towel dry the hair so the scalp's not sopping wet. I warn patients to treat any scalp dermatosis. Do not give this to an itchy patient or a patient with uncontrolled seb derm. You're asking for trouble. Warn them about the increased shedding, because if you don't warn them, they're going to call your office crying, and it'll save you a lot of phone calls. And I tell them, work it into your schedule. One day you may use it in the morning. The next day you may use it after the gym. Like, it doesn't have to be the same time every day. So it's really important, if you're going to give patients minoxidil, that you spend a little time discussing it. And what about low dose oral minoxidil? I wonder, I can't ask you guys how many of you are using it, because I know you can't really answer me. But the first paper that I saw on this was in 2018. And this was a paper out of Australia by Rod Sinclair. And he treated 100 women, and the dose was so low, it was 0.25. And he combined it with spironolactone 25. But look at the age range, 18 to 80, right? Pretty bold. And they had a reduction in hair shedding. The patients were happy, and they were pretty minimal side effects. Hypertrichosis was accounted for half of them. There's a little bit of, orthostasis, but very little. And interestingly, orally, 22% of patients had increased shedding within 6 weeks. So that's kind of the number I use to my patients. And I say 1 in 5, which is a lot, you may get an increased shed. And typically it lasts a month, but in a quarter of the cases, it lasts longer than that. So the latest study that's from 2008, jumped 3 years. Now you're seeing 1,400 patients treated with low dose oral minoxidil. And now the doses are a little bit higher. The doses in this study ranged in women and men. In men, it's a higher dose than women. The women were 0.25 all the way up to 5. And I think the men went all the way up to 12 in some patients. And look at the age range, 8 to 86. So this is a pretty wide group of people that are being used. The most frequent effect was hypertrichosis. And this is the number I quote, 15. But it's interesting, when I review the paper for this talk, the 15 included men and women. So in women, it's probably closer to 20%. That's probably the number that you should use. And the lightheadedness was like less than 2%, along with a little bit of edema, very little tachycardia, very few side effects, and only under 2% of patients stopped it for side effects. So it's actually very well tolerated. So I think this is a great option for a lot of people who either get irritated from Rogaine, who just can't keep up with it because they don't like putting it on their heads. So for men and women. All right, I think you guys probably know about this. I just think it's important. This was a study out of the Brigham, actually, in 2015 that looked at monitoring for spironolactone. If you have young, healthy acne patients, they didn't talk about the dose, but they did mention young, healthy acne patients, that there was really routine potassium monitoring is not necessary. They excluded in this study people with cardiovascular disease, renal failure, ACE inhibitor use. So you have to be a little careful as your patients get a little bit older, as they start developing a med list. If they have some hypertension or some definitely kidney disease, you have to be a little bit more careful. But I don't think we have to do a lot of monitoring for potassium, just so you know. All right, what about finasteride, right? Everyone knows about finasteride for male pattern hair loss. It's been approved a long time ago, 1997. It blocks type 2, 5-alpha reductase. After 2 years, 1% of patients had less hair. That is great. I mean, that is a great stat. It works really well, right? And after 5 years, only 10% of people had less hair. So those are pretty impressive results. And we all knew that it decreased the PSA, and we would have patients just mention it. Well, those were the old days, right? I think minoxidil has a lot more problems now. I don't know how many of you guys saw this in the recent Dermatology Times about this lawsuit. So there have been some emerging issues with finasteride for male pattern hair loss. So the labeling was updated in 2012 to include sexual side effects, that can be long lasting, as this paper shown here. Again, we didn't see a lot of this literature because it's in the journal Andrology. It's not, a lot of it wasn't in the Derm journal until very recently. And it talked about depression in patients, but not suicide. And when this happened, it unleashed numerous lawsuits from Merck, which has since now been settled. So this is not an active problem per se, but it was later reported that the FDA had received reports of sexual and mental health issues, including suicide, dating back to 2009. And there was a recent suit, that's what this article is about, filed on behalf of the Post-Finasteride Syndrome Foundation. That's an organization founded in 2012 to promote education about finasteride and research on its side effects. And this organization really wants the medicine removed from the market. And if you look here, I did a little literature search on suicide and finasteride, and you can see, I'm going to move you guys because you're in my way here. I'm going to move you up. So you can see that the first paper was in 2012, but look what happened in 2021. It's really kind of taking off. So you may be asking, well, what do I do? Do I stop using finasteride? Can I still use it? Well, I think we need to be transparent, right? We need to inform patients that adverse effects do exist. They can become long lasting. I tell patients to stop if they have any side effects, but you have to tell them that these adverse effects are incompletely and inadequately assessed. The data reporting is not really uniform, and it really needs further investigation, but I think there is something to it. And I think we should screen our patients prior to prescribing. And I've always asked about erectile dysfunction, but now I think I also will ask about if they have a history of depression, and certainly I may or may not come out and ask about, suicidal ideation, but I think we should ask about it. And I think it's important. All right. You guys asked
Dr.
about
Goldberg,
low level.
yes.
Yes.
I have a quick question. We
Sure.
have several that are popping up. Do you want to address them during the presentation, or do you want to address them at the end of the presentation?
Well, I think we can start during, and if I find that we're like running behind and we're not going to finish, we can ask to hold. So go ahead. Why don't you go ahead?
All right. So Dr. Stitt asks, constipation with oral minoxidil, one patient complaining of this.
Well, one patient may complain of that. I don't think it's a frequent issue as far as I may not ask my patients about constipation, but I don't think it's a frequent issue. It's nothing I would counsel about.
All right. Dr. Bostrom asks, is the hypertrichosis associated with low dose oral minoxidil generalized?
So that's a good question. When they talk about the hypertrichosis, they're mostly talking about along the jawline. I suppose I have had individual patients have generalized hypertrichosis even from topical minoxidil. It's not common, but it can occur. But I think in those numbers they were referring to jawline, is my understanding. I'd have to go review their article to be sure, though.
Great. And then Dr. Jenkins asked, who would you not give oral minoxidil to, given your presentation of tolerability?
I think you have to be careful in the elderly, although I do have some 70 people, year-old people on it. You have to be careful of someone who tells you their blood pressure runs low, someone whose baseline gets dizzy. I wouldn't give it to people who run low blood pressure. I might not give it to someone who is requiring, 3 antihypertensive meds to control their blood pressure, but it doesn't really have much effect on blood pressure. So it probably could be used safely in that person, so I think it's a case-by-case decision. And the other thing is you can start with a lower dose, right? If you're hesitant, if you want to give someone, you think it'll rock their world, you can give them a quarter of a pill. This pill is commercially available in a 2.5 milligram dose. My typical starting dose is 1 point, like half a pill, which is 1.25. But if I have someone who I'm nervous about, or sometimes the patient is nervous, I can give them a quarter of a pill, so 0.6. And if they don't tolerate that, then we just stop it.
What is your approach? Dr. Thompson asked, what is your approach to spironolactone and history of breast or GU cancer, whether in patient or family members?
Yeah, I mean, that's a very good question. I do talk to patients who have either a personal or family history of breast cancer. I think it is unknown. I think it is theoretical. I think it is possible. If the breast cancer was recent, I can involve the oncologist in the decision making. If it was, a lot of patients have like a distant history of breast cancer, many years ago, small tumor resected, I leave it up to them. I mean, I have a discussion, but I think you definitely have to talk about it. And there are some patients who just will not, decide they don't want to do it, and that's fine. I think it's theoretically possible, but we don't have great data on that.
All right, and last question for this set. Any handle on the actual percentage of post-finasteride syndrome and side effects, or are we just in the case report land?
You know what? I don't know if we're even we are definitely in the case report realm, but the data that's coming out is using the World Health Organization Vigibase data, the reports that are going to make it into the derm. One of them was already published by JAMA Derm, looking at depression. So they're looking at self-reported data, not even case reports, patients who report or doctors who report, depression, anxiety events on these drugs to the World Health Organization. So it's multiple different countries, and that's the data that's being used.
Great, thank you. We'll move on for now, and I'll let you know if more questions pop up.
Great, very good questions, you guys. All right, low-level laser light therapy, right? This was a device that was cleared, not approved by the FDA. It's FDA cleared, safety clearance in 2007. And then as 7 years later, there were 4 more cleared by 2014, 4 more in 15, and then many others since then. Most of them, the ones that got cleared after the original one, are based on the same technology, because that way they don't have to redo the studies. They all use the same wavelength and they get grandfathered in for the clearance. So we don't even know if this wavelength is the best wavelength. Is this, are there other things that could be better? There was a recent one called Revian Red that was introduced that uses 2 different wavelengths. So that's probably, the latest and greatest thing, but we really don't know. They haven't been studied against each other. The data has a lot of holes, but there was a meta-analysis showing that it did help some patients. So I think this is a great thing to offer people who don't want to take minoxidil. They don't want to use any, I have a lot of patients who don't want chemicals, quote unquote. So this is a nice adjunctive thing that you can do. The problem is the patients can't tell that it's working. They're like, how do I know if it's working? I'm like, well, take photos before, try to have a money back guarantee in case you don't like it, in case it's uncomfortable. And if you're not worse, then it could be doing something. So that's what I have to say about that. How does it work? Right? People ask that. Well, the light acts on the mitochondria, on cytochrome C oxidase, and that releases reactive oxygen species and ATP and nitrous oxide. Now, nitrous oxide is in and of itself a vasodilator. So no one really knows if that's a big piece of how it works, but the reactive oxygen species generate kinase pathways, which then generate transcription factors. You can measure the whole pathway, and there are cytokines and inflammatory mediators, and ultimately there's increased proliferation of the cells either in the bulge or the dermal papilla, that keep the hair follicle in anagen is the goal. So this is how it works. And there's a lot of overlap between this, it's interesting, and how minoxidil works, especially with the vasodilation. So, and this may work other ways. There was another paper saying that this is anti-inflammatory, and a lot of people believe that the low-level laser light is really decreasing inflammation. That may be why it works not only in AGA, but in other diseases as well. So I don't think we really know. This is a proposed mechanism. People asked about other things. There's microneedling, right? This was first done actually for acne scarring. It creates channels in the dermis. It can be done by either a roller, as you see here, or a pen. There's minimal damage to the epidermis, and it's used for its effects on collagen, right? Facial rejuvenation, for its effects on hair follicles, as well as a drug delivery system. Like some people use it with their Rogaine to increase penetration. What does it do? Well, here's a picture of a 1 millimeter needle. For the scalp, we generally recommend 1.5 millimeters. I know for facial rejuvenation, people can start with 0.5 millimeters. So there's trauma, right? Microtrauma releases growth factors, and these growth factors stimulate production of collagen in some patients, and also in the hair follicles and the dermal papilla to stimulate hair growth. So I think this is there's not too much written about it. Some people who've maxed out on Rogaine can increase their hair growth using a roller once a week. Some of the papers start with once a week and they go to once every 2 weeks. But I have some patients who are really excited about this. You know what? It's cheap. You know, you can go on Amazon, buy yourself a roller. I went out and bought one, you know, but the problem is you have to clean it. Like that was just kind of a pain. So, but it definitely can be done. And the needles don't last forever. It's going to dull. So you do have to replace them periodically. But some patients, again, are very excited about this. So let's talk about PRP. Some of you guys may already, may be doing this in your office. It's derived from whole blood, enriched in the platelets. It started out actually for wound healing. And then over the last decade or so, it spread to other disciplines, including the surgical disciplines, including dentistry, ophthalmology, and it made its way to dermatology, first through the surgeons, through hair transplant surgeons, and then to medical dermatology. And it's used in acne scarring, facial rejuvenation, and in alopecia. Well, we're all familiar with platelet function in wound healing, but platelets actually have an emerging immune function, both the innate immune system as well as the adaptive immune system. And it involves not only antigen presentation, but T cell responses and B cell responses. So a lot of immune function of platelets. You can see here, they're tiny. Those are the red blood cells that they're being compared to. And you can see they're little fragments of cells, right? And in these tiny little fragments of cells, when you blow them up, there are granules that are a storage system for mediators. And there are over 800 mediators in these tiny little platelets. And they're stored in the alpha granules, in dense granules, lysosomal granules, but it's the alpha granules that have the growth factors for the hair follicle. And you can see there are many, many growth factors, too many for me to list, I had to squeeze them in here to this slide. So this is how it works, right? The growth factors will bind to their receptors, and there are many different pathways that are circled in red that stimulate both proliferation, differentiation, right? Vasodilation, decreased apoptosis, and increased survival, which ultimately lead the hair follicle to be in anagen. And that's what we're looking to do, to keep the hair follicle growing, to stop the shed, and possibly even to keep it growing a little bit bigger, although most of it is it's a cycling benefit. All right, so any questions about microneedling, PRP? We can pause.
It looks like there's some questions that came up. So Dr. Ryan actually posted a comment about the unfortunate case of a dermatologist colleague who committed suicide coming off of finasteride that they think may be post-finasteride syndrome. That was more of a comment. And then Kelly Noska says, she asked, have you had any success treating LPP with low-level laser light caps in patients who cannot tolerate systemic treatment and still have active disease despite multiple ILK injections? If so, any recommendations on devices?
So I have not used low-level laser light for patients with LPP. I tried to there was a UVB device that is marketed for psoriasis. That is it's a scalp device. I tried to get that covered for my LPP patients, but I was unsuccessful. So, but no, I haven't tried the low-level laser light, but I think it's worth it. It's a cold laser. It's not a hot thing, so it shouldn't be irritating, but I just don't know if it will work or not.
That's a great point. Yeah, I think personally, I've also seen excimer laser being used on LPP because it's similar, I guess, to LP. Yeah. Dr. Jenkins asked, is there any data to support increased percentages of topical minoxidil and or the combined products with retinoic acid or salicylic acid? Also, is there data to support topical spironolactone?
Right, so I don't use a lot of the topical mixtures. There are pharmacies that will compound them and give you a whole list of things that you can compound. I think there could be a role for that, for patients who don't want to take oral medications. I do use some compounds in my practice, but I don't do a lot of those. So I think there is a role. I know in Europe and South America, they use higher concentrations of minoxidil. It is concentration dependent, and there is variation in patient sensitivity to minoxidil. So if you have someone who's not very sensitive, who's not getting a lot of facial hair, who's not getting a lot of reaction, I think you could go up on the, compound the dose. But yeah, I don't use a lot of the other things.
And Dr. Okereke asks, thank you for the talk. For how many minutes do you recommend patients use the microneedling device? Excuse me, microneedling device.
So I think the early papers that talked about that didn't really talk about minutes. They talked about 3 passes. So you go in one direction, then a second direction, and then a third direction, and that's enough.
All right, thank you.
Yeah, I don't think we know, and I don't think there are studies on that, at least not that I know of. Maybe more for the facial rejuvenation, but not for the hair. And it's much easier to use in the temple than it is on the crown. You can imagine like trying to roll your crown and having the hair roll in it. So if you're going to try the crown, you have to part your hair, pin it down so that your hair doesn't roll. So you want to be opposite the hair growth.
Thank you so much. I think that's it for this round.
All right, let's see how we're doing. All right, moving right along. So supplements for AGA was one of your questions. Obviously, it's indicated for any patient with a documented deficiency. And I think we should all be aware of the kind of patient populations who might be at risk for vitamin deficiency. Those are the elderly, just all around. Patients with GI disease and ETOH abuse also may be low on fat-soluble vitamins, iron and zinc. Hemodialysis patients, and I think what we're going to see more often are vegetarians, right? It's very common these days, and also just women who menstruate are at risk for iron deficiency. So probably iron is one of the things that I do check for when I do a workup, and certain medications can also put you at risk for iron deficiency and deficiency of zinc, just something to be aware of. The problems with studies on supplements is that they're done on patients with different types of hair loss. Sometimes they just give patients with hair loss the supplement, and that's the data, and you don't know what the patients had. And the other thing is these formulations have multiple ingredients, and it's hard to tease out which ingredients is helping the patient. And the other thing is that they've only been studied for like 6 months at the most, so that no one knows like what happens if you supplement for 6 months and then you stop. I have every reason to think that probably the effects will go away. So we don't know. Patients say, do I still have to take this stuff? And you're like, well, I don't know if you still have to take it, because I don't know if you have to take it in the first place. So it gets a little bit tricky as to how long and what to do. So that's my issue with supplements. I think most people in this country are not protein calorie malnourished. Most patients do not have vitamin deficiency, but every now and then, there is a case, and you just need to be aware of that. Like, but gastric bypass probably should be on that list as well. That's probably what I see most. All right, case 2. So I'm going to kind of move into the scarring world now in the last 20 minutes or so. So these are kind of true stories. So this patient's biopsy, this could be your patient, right? And the biopsy was read as alopecia areata. Well, I don't know about you, but if there's one thing I know is that this patient does not have alopecia areata, right? So how could this happen? Well, maybe it was sampling, right? Maybe they just punched the hair and not the red area. Maybe the lab switched the specimens. I mean, I'd like to think that doesn't happen, but I mean, it could happen, I guess. Maybe it was something else. So here's the biopsy, or a representative biopsy. I think this might have been this patient's biopsy. And you can see there's a lot of small hairs, a lot of, you may not be able to see that, but these are very small hairs, especially the ones on top. There's some cycling hairs here, that's abnormal, but you have sebaceous glands, and it looks overall pretty healthy, like not a whole lot of inflammation. And this is another patient here on the left, but you can see here, if the biopsy is superficial and it doesn't go deep, you're going to miss the bottom part. Look at the bottom part, total wreck here, diffuse inflammation, no collagen, no subcutis, nothing. And there's no way looking at this top specimen here that you would anticipate is that this is what it looked like down below. So the problem here was that it was a superficial biopsy, and it was relatively normal because the money was was deeper. So this is dissecting cellulitis of the scalp. This is most common in Black men in their 2nd to 4th decades, but I do have Caucasian patients who have this, so it's not limited to Blacks or African Americans. It can start as a solitary nodule. You'll think it's a cyst. You may even excise it, and you'll get a pathology report that says, you know, inflammation, no cyst lining is seen, which can happen. But then the patient gets a second one, and then you have to have your antenna up to pick this up. Then they increase in number and they become interconnected and they drain. The whole idea is to treat it sooner rather than later, right? There's a lot of confusion in the neutrophilic scarring alopecias, right? It happens at meetings. There's confusion between dissecting cellulitis and folliculitis decalvans. Dissecting cellulitis is the one that causes the nodules. They're soft, they're boggy, they can drain, and then they can be multiple ones. In folliculitis decalvans, it's a patch of hair loss that has a smooth surface. Sometimes you can have pustules. The problem is it rarely looks like this. This is one of my patients who was flaring as I switched his antibiotics. Now I know to overlap antibiotics when I switch them. The nicest guy in the world, you know, and he had terrible scarring. I mean, he had scarring before, but he definitely flared. So the problem is that folliculitis decalvans doesn't always look like that. It looks like this more often than not. And this patient comes in, clearly has a scarring alopecia, and you often diagnosed with LPP, right? Because it's not inflammatory, there's no pustules. But when you get out your derm light, and the derm light is an essential part of the hair clinic. I could have given you a whole, put in a whole 10 slides about why we all need our derm lights in the hair clinic, but I didn't have time. But if you get out your derm light and you look, you can see there's tufting. Tufting is not 1, tufting is not 2, tufting is like 6, multiple hairs from a single orifice. And this is a high power of a dermoscopy picture of folliculitis decalvans, and this is what LPP looks like in comparison. And you can see there's individual hairs with rings of scale. It's not the tufting that looks like this. So be on the lookout for this because it happens. All right, so the big difference between dissecting cellulitis on the left and folliculitis decalvans is the depth. And these are representative biopsies. And if you cut them in half, you can see the inflammation in dissecting cellulitis is deep. And the inflammation in folliculitis decalvans is superficial. Done. All right. So let's take a step back. We're talking about the neutrophilic things. We know most of the scarring alopecias are actually lymphocytic. These are a group of diseases that destroy the hair follicle. They can be primary or secondary. I'm assuming you guys know the difference. A primary scarring alopecia is pretty much what we're discussing today, an inflammatory process that destroys the hair follicle. A secondary scarring alopecia are hair follicles that are destroyed by another process where they're incidental, they're innocent bystanders. And these are classified histologically into the neutrophilic ones that I just showed you and the lymphocytic ones. And clinical pathologic correlation is so important in making these diagnoses. It really does take a village. The clinical distinctions, as I've showed you, are very difficult. And even the derm path can be very difficult depending on the lives of the lesions, how active they are. So I'll ask you a question I know that you can't answer. And the question is, which patient has scarring? Well, obviously, this is a trick question, right? Because both of the patients have scarring. And it might have been a little bit easier if I had showed you the patient on the left, if I showed you her eyebrows. So this is frontal fibrosing alopecia. This is a primary scarring alopecia. And the woman on the left has traction alopecia. Notice she's an older woman. You can see kind of the gray hairs, but it's very, very hard to tell these apart. Now, some of you may say, well, Lynn, what difference does it make? It's a scarring alopecia. The hair's not going to come back. And it does make a difference. You know why? Because traction alopecia can be transplanted because that's a healthy scalp. The sebaceous glands are intact, and you can move hair from the back, fill that in if it's a small area, or fill in the front, give the patient some coverage. Whereas if you transplant FFA, the grafts may hold for a little while, but eventually they will lose the grafts. So I think in that terms, there is a difference and a reason to make the diagnosis. But the problem is patients can have both. And African Americans, look how healthy the scalp looks on the left. They can have retained orifices with FFA. These are the classic patterns of lymphocytic scarring alopecia. There's CCCA on the left, where you just have a central loss, either on the crown or the vertex. There's LPP in the top middle of just patchy hair loss, as we talked about before. This frontal fibrosing alopecia, which I'm going to talk more about, and this discoid lupus on the right, which tends to be more annular, more pigmentary change, has an active border and follicular plugging. I'm not going to be talking too much about that today. All right, believe it or not, this patient was the first patient I ever saw with FFA. It came from a current AP derm practice. And I know the clinician is in the audience if they remember, but this was 2005. And from there, this is my plot of the patients who I've seen in my practice since then. And you can see it's just gone sky high. This is an epidemic, this disease, and we don't know why. The clinical features of FFA, most of the patients are postmenopausal, but look at how that's coming down. And I'm working on a report right now where even, I believe the age is coming down. Up to 10% can have LP elsewhere. Notice how many have coexistent AGA, and sometimes you can treat that to really help the patients. There can be occipital loss. I don't think that's widely known. Patients who are bad go all the way around to the back. We know about the brow loss, very common, but there can be beard loss in men, lonely hairs in 50%, I'm going to show you that, and the characteristic facial papules in 14%. So this is the so-called lonely hair. This is a big terminal hair seemingly coming out of the forehead. Now, in an older person, you don't really need the lonely hair to tell you where her hair loss is, because you can see the wrinkles in the rhytids and the lentigines below and the smooth white scalp surface above. But in a younger patient, right, where you don't have the sun damage, the presence of the lonely hair seemingly coming out in the middle of the forehead can be very helpful to tell you where the hairline was. This is a guy who has FFA. I do have men with FFA. You can see his characteristic eyebrow, diffuse eyebrow thinning, the sideburn thinning, which we published, but he's also got the facial papules. And these patients have presented to our cosmetic dermatologist complaining about the texture of their face. And then she diagnosed FFA. So you have to be aware of the so-called facial papules. They're classically on the temples, but they can be elsewhere on the face. And this is lichen planus pigmentosus, which has been reported in FFA patients. It can either look kind of reticulate and red, or in dark-skinned patients where it's more classic, it can be red-brown. And biopsies have shown that it is a lichenoid dermatitis. It looks a little bit different. It's not like lichen planus, but there is a band-like infiltrate. There are colloid bodies, and it accounts for the pigmentation. So just be aware of that. All right, the last scarring alopecia I'm going to talk about is CCCA. We know, I showed you before, the scarring alopecia in a central distribution. On dermoscopy, there's characteristic white, perifollicular white halos. And you should be aware that this is a disease of young people, that this is not a disease necessarily of older people, and it can present with hair breakage. So people with hair breakage may need more than just a conditioner and a change in their shampoo. They may also need a topical steroid, so just be aware of that. And this is a picture ostensibly of a patient presenting with hair breakage. I do think there is a little bit of loss here. The paper said there was minimal loss, but I'll let you guys decide that. But it's just an important take-home message, I think. All right. I think there are a few new things to talk about in CCCA. It's actually been quite a lot of written, and I spoke about this in the DermPath meeting as well. There was a study showing of families, plotting the family trees, showing that there was autosomal dominant with partial penetrance, without obviously a modifying effect of hair practices. It does belong to a group of fibroproliferative disorders. And there's been a lot of literature on these. And these fibroproliferative disorders are things that you wouldn't necessarily think of. Like, yes, keloids are in there, but like leiomyomas are in there too. And as a pathologist, I'm like, well, those are smooth muscle tumors. But again, smooth muscle, is a modified fibroblast. I don't know, there's some connection there. So the group of diseases includes like asthma also, like things that you wouldn't think of specifically as fibroproliferative. But the thinking is that it's a response to helminth infections that were rampant in sub-Saharan Africa. And genetically, this has morphed over time, resulting in a pro-fibrotic gene to encapsulate the organism that causes fibrosis in other organs. And there was actually an association found between CCCA and uterine fibroids. So you should ask your patients, because it's not actually uncommon. And the biggest news, I think, that hit the New England Journal was the PADI3 gene. Probably heard about this. This was a study done on patients at I believe it was Wake Forest, and also in South Africa. They had a discovery group where they looked for the genes, and these genes were specifically target, things that changed proteins. And then they applied what they found to another group, and they found in total that these mutations were found in 24% of CCCA patients. And that was, not a random finding, and it was significantly different than the control group. So this is actually a genetic this could be a genetic disease. And the fact that it's only found in 24% likely points to the heterogeneity of this disease. I mean, there are probably other factors as well. But, you know, in the old days, I have some of my colleagues, when I read their notes, they like blame the patient. Well, this lady has relaxed her hair for years and now she has CCCA. You know, you like put the blame on the patient. But I think that it's not really, we shouldn't be playing the blame game, because I think there are other factors. And I think this is really very important in changing our thinking about this disease. How are we doing? Good. In the last 5 minutes, I know what you're all interested in is treatment. So let's talk a little bit about treatment. I think the treatment of the neutrophilic things overlaps. I tend to go to antibiotics first in my practice, for both diseases, and we can talk about that. But mostly it's oral. Sometimes if it's very limited disease, you can do topical. I have patients who've gotten a lot better with both of these diseases with topical antibiotics, especially if they had very few lesions. Tacrolimus, there's some literature on its use in folliculitis decalbans. I don't use it much because it's, you know, the ointment, but you can do that. And certainly intralesional systemic steroids, very effective. And I don't use rifampin and Clinda as a first-line agent, but I will use that as a second-line agent, you know, after other oral antibiotics if individual antibiotics don't work. It's said to maybe give you a little bit of a durable response, but some patients do need repeated courses. I do use dapsone as a second-line agent. You can use Accutane. You know, I don't use a lot of Accutane in my practice, but you can. And certainly you could try biologics. Now, Accutane and biologics have gotten more use in dissecting cellulitis. You know, I do start with oral and topical antibiotics, you know, systemic steroids, intralesional steroids, but you can go to isotretinoin. Some people believe that isotretinoin should be first. It's kind of a debate in the literature. Sometimes they need a low dose, sometimes they need prolonged courses, but biologics have really changed people's lives with this disease. I'll show you that. Under dire circumstances, people have excised, people have scalped patients. Laser can be used, but it doesn't really help the hair loss. It just helps the inflammation. And I have a guy who's an engineer. He really had him on antibiotics. He didn't want to go on Accutane. And he just, whenever he got one that drained, he pushed it and he devised a headband. And we actually published this in JAMA. And just from the pressure, he was able to heal all of his lesions very, very simply. But it was a very intelligent and very motivated patient. All right. This is what TNF alpha inhibitors do to dissecting cellulitis. It's amazing, right? Who would have predicted that this patient on top would have grown that much hair, right? I would not have predicted that. And I think that what happens is, like I told you, all the inflammation is super deep and a lot of the problems on top are pressure. So when you know, like my patient who pushed out the pus, when you get rid of the pus that's deep, a lot of these follicles are just kind of dormant on top and they grow hair. So this is amazing. This was maintained after a year. This happened right around the time that BU and Tufts were still combined, and Alice Gottlieb was at Tufts, and she was getting a lot of these drugs for her psoriasis patients at that time. So she used this patient, she used adalimumab on this patient at Tufts, and you can see he was miserable with this disease. He hadn't responded to anything. It's painful. It's not just unsightly, it's painful. And he was thrilled. This is 5 months later. So the TNF alpha inhibitors are great for this disease. Just keep that in mind. I'm going to talk a little bit about 5-alpha reductase inhibitors for FFA now, not for AGA. This first came out in a paper from Duke in 2013, and they used both dutasteride and finasteride. Before I go into this, I just want to tell you just a quick second about dutasteride. It's like finasteride on steroids. It's a stronger 5-alpha reductase inhibitor. It inhibits both types of the enzyme, and type 1 is in the epidermis and sweat glands and dermal papillae. It's a tiny dose, right? We use 5 milligrams of finasteride. This is a tenth of that, inhibits 90% of DHT, versus a 5 milligram dose of finasteride inhibiting 70%. It's a very potent inhibitor. There are similar side effects to finasteride. Interesting though, this post-finasteride syndrome people in the database, it didn't happen with dutasteride, which is why skeptics are also skeptical of this. And I do think there's something to it, and I do think it's important, but it didn't really happen with dutasteride. Anyway, back to that slide. So after it was first described in 2013, 7 of 10 patients responded with FFA to dutasteride, and 1 of 3 responded to finasteride. You can see they didn't use dutasteride in the premenopausal women. But if you look at this, the Spain the Spanish data, and I think the Spaniards are really pioneering this. This was a study in 2014 that you may remember. Look at this. People did well on ILK, right? 34% improved, or almost 50% stabilized, only 5% worsened. People did fine on Plaquenil, improved, stabilized with 20% worsening, but nobody worsened on finasteride out of 100 patients, and nobody worsened on dutasteride. It's kind of hard. I don't know. It's hard to believe that, but really, I mean, they've had very good experience with it. Then jump to 2021. This was a recently published paper that actually one of my patients brought into me, and it talks about effectiveness of dutasteride in FFA. But you know, the problem is this really wasn't a study. They were just looking at their patients as they treated them, and dutasteride was their first line treatment. So it was not a study. All the patients also used minoxidil and clobetasol, so they weren't just using purely dutasteride, and they compared it with finasteride, but only 4% of the patients got dutasteride, and only 2.7 got Plaquenil, and 1.3 got doxy. So it's not really a fair comparison, but they did feel that dutasteride had the highest stabilization rate. It doesn't have to be given every day, so if the patient misses a day or two, it's okay, because they tried different intervals, but 5 to 7 days was the best. And at 2 years, 57% stabilized with dutasteride versus 50% with finasteride. It's not a big difference. But 22% stabilized without therapy at all. So I don't know, you have to kind of read this paper critically. It sounds like it's great, but I don't know. I am still using a dutasteride in my patients, probably a little bit more, because I think it has a very good safety profile. So it's easy to use, especially in the older patients who have FFA. This was published, so there are people's practical guides to their ladder for treating FFA. I think something you can all take from this talk is that you have to have your own ladder for the scarring alopecias, because the data just helps you, but it's not great. So this group likes to use topical corticosteroids. I'm assuming this is calcineurin inhibitor, this TCI, minoxidil, intralesional Kenalog, and a 5-alpha reductase. Look at this as their number one, right? And if no improvement, then they go to hydrochloroquine, very interesting, right? And then they talk about all retinoids, pioglitazone, naltrexone, and Cellcept or methotrexate. I think it's interesting here that there are adjunctive therapies, low-level lasers, PRP. That someone asked me about PRP, and oral minoxidil. So treatments for androgenetic alopecia in scarring patients, because just improving the rest of their hair can improve the appearance of their FFA. My treatment ladder is a topical steroid, ILK. I will go to doxy before hydrochloroquine, just because I didn't have appointments really for the monitoring. You can also use the 5-alpha reductase inhibitors. I think I've moved up in my systemic therapy, and then there are all these medicines, other second line. For CCCA, there are two components. There's the anti-inflammatory component. Most people respond very well to topical steroids. I use doxy. In the literature, you can use 100 BID for 3 months for select patients who have pustules, who are very symptomatic, as well as antifungal shampoos. And then if the hair loss is an issue, you can try to add, as we talked about, minoxidil. You can throw PRP at that, the other things also. And there was a recent paper on topical metformin, 10% cream, which is really super interesting. And here's a picture from that paper that the patient actually, they felt that the patient actually prematurely grew hair from that from metformin. So we're thinking maybe other antifibrotic therapies are going to come, because as the thinking is that this is a fibrotic disease more than an inflammatory disease. And on that note, I want to thank you all for your attention. We are just 5 minutes late. I apologize for that, but I'm happy to take any remaining questions.
Thank you so much. That was amazing. I was taking notes myself on all the different things that you mentioned. We do have a number of questions. So Dr. Iliadis says, any protocol for low-level laser light therapy?
Protocol in terms of, so from that question, I'm gonna think that in the old days, and some people still do offer low-level laser light in their offices, right? When it first came out, they would buy a device and have patients come in and administer it. Then these devices that I've showed you came out, and now most people will do low-level laser light at home. They will purchase a device and do it at home. And the amount of time that they do it, it's usually 3 times a week. It's usually anywhere from 20 minutes or so, depending on which device, how many diodes there are, how strong is the device. And the differences between them, some of them have like, earbuds, I mean, some of them have a timer, so, and most of the wavelengths are the same except for that new Rivian red one. So that's the best way I can answer that.
Thank you. Dr. Okereke, she just makes a comment and says, yes, hair breakage, particularly at the crown. I guess that was for the CCCA comment. And then she asked, what is your maintenance regimen for patients? Oh, sorry. She says, please disregard, sorry.
Oh. Okay.
If you can clarify that, that would be great. We also have another question from Kristen Menke, who asked, what is your go-to treatment for an LPP patient who failed Plaquenil?
Well, I think you need to have your own, ladder. My first line agents, if I need to go systemic, are doxycycline and the 5-alpha reductase inhibitors. I generally don't have to go much beyond that. You could go to Cellcept, I would consider. If someone's flaring dramatically, a course of systemic steroids can really just calm somebody down quickly. You could do a brief course of, what is it? I had it in the lecture, the diabetes drug. Hello.
Metformin?
Yeah, pioglitazone. Thank you.
Yeah.
Thank you, Toby. Yeah, pioglitazone. It did have some bad press about the bladder cancer thing, but I think that's very controversial also because diabetics can get bladder cancer. So that can also be used, in a pinch. But I would say Doxy or one of the 5-alpha reductase inhibitors.
Great. Katie O'Brien asks, what is your opinion on finasteride for women?
So I took that slide out just because I wasn't covering that, but I think that there are maybe 6 or so case reports of use in finasteride for AGA in women. A lot of the women have had good results. So I do use it in women. I do ask again about the breast cancer thing. And now I started asking a little bit about depression because I have had some women tell me that they're fatigue and depression, and some women have stopped it. So we don't have the data, the World Health Organization vigil-based data on that, but I think it's worth asking. But I do think it is effective in AGA in women, not only finasteride, but dutasteride as well.
Great. Dr. Toyohara, who's also our dermatopathologist, says she echoes your comments about the need for deep biopsies for alopecia and large biopsies, at least 4 millimeters. So many specimens come in without actually even reaching fat or the follicular bulb that is needed. And also the clinical information is always important.
I totally agree, as Dr. Toyohara knows.
Dr. Milhot asks, is there a recommended treatment for the facial papules? That's a good one.
Yeah, I think that if you look in the literature on that, there is a discussion about Accutane helping the facial papules. There's some controversy about whether they're actually sebaceous glands associated with the hair follicles. So as a first-line agent, you could do Retin-A and try that. Some people have had improvement, and you could try low-dose Accutane if you were so inclined.
Great. Dr. Stitt asked, alternative anti-inflammatory agents of choice when antibiotics, Plaquenil, steroids don't work for FF. I guess you mentioned this as well already. Yeah. So I think your answer is already.
Yeah. There are some people who are steroid averse, and there are physicians who use compounded tacrolimus powder in like Cetaphil, so they can use compounded tacrolimus in a solution and not in an ointment because it's so sticky. So pharmacies, compounded pharmacies are familiar with that product and can make it if your patients are steroid averse.
Great. And Dr. Stitt, if this doesn't answer your questions, because you had a couple of questions, please let me know. And then Anna Pozzarni asked, how long do you typically keep a patient who has LPP or FFA on Doxy or Plaquenil?
Again, a very good question. We don't have much guidance. I mean, the whole point of treatment of these diseases is to follow the patients, When the inflammation gets better, when there's less perifollicular scale is the most important thing that I use, then you can taper. And some patients are afraid of tapering, so you kind of have to maybe do it slowly, tell them it takes about 3 months before they'll notice a flare. So you can do a little taper, 3 months, then a little bit more. But I think you have to follow them and get them off as soon as you can. I have some patients, again, they don't want to come off. And I say, listen, if I keep you on everything and then you get worse, I have nothing else to add. So I really, I need to take you off when you're better so we can add when you're worse.
Great. We have 2 more questions. I know we're running out of time, but thank you so much for being so gracious to answer all these questions. So either Dr. Sands or Dr. Muse asked, as far as systemic steroids, is dexamethasone 4 milligrams pulse twice a week worth trying like we do for vitiligo?
So I can't really answer to that because I don't use a lot of systemic steroids. I certainly think you can if someone is flaring and at risk of losing a tremendous amount of hair, because the hair loss is permanent. And so if you really need to stop it acutely, I think steroids are a great option. But I'm just not familiar with pulse steroids because I don't use them.
Great. And last question, any hypotheses on why the steady increase of FFA in recent years?
Such a good question. I am seeing women in their 20s. It is petrifying. It is petrifying. So those of you who think it's a disease of postmenopausal women, you are wrong. So I'm not sure I buy the hormonal thing completely. I'm not sure I buy the facial surgery thing completely. Maybe it is something in the environment. There is good data. The genetic data looks like a contact dermatitis could be, a thing. So yeah, I don't know. It's fascinating.
Thank you so much. I mean, from all the questions and all the engagement we got, I know everybody really appreciated it. So we definitely appreciate your time, Dr. Goldberg, and you are always welcome here.
Thank you. Thank you so much. I told these guys my first job was at AP Derm, but probably, well, some of you were in diapers or not even born. So, on that note, I say hi to all my former residents, including Dr. Rainham, who's going to speak to you next. And I'm going to sign off. So thank you very much. Good night.
Thank you. Good night.
Thank you, Dr. Goldberg.
All right.
All right.
So excited to continue the conversation. Last time, I'm sure you guys all remember that we spoke about how to maximize your practice at AP Derm. Dr. Rainham has a wealth of information on really working with the referring docs who send their patients to us. And we've actually just run some surveys to see where our new patients learn about us. And the vast majority of them are coming because their primary care docs send them to us. So it's actually really important for us to reach back out to them. So I'm going to pass back to Dr. Rainham. So please share all your pearls that have helped me even personally.
Thank you so much. I'm just wondering, am I able to advance the slides, or will somebody be able to advance them for me?
I have them here, Dr. Rainham, and I'll advance them as you request.
Okay, thank you. If you could start with the first one. So, yeah, thank you. So the most important thing actually is to think as if you are the primary care physician, the referring physician. And you've really got to get into their mindset. They often are very, very busy. They don't have many support staff. They often are running around themselves, maybe sort of ordering labs, making those phone calls. And so they haven't got much extra help and much time. They also are extremely protective of their patients. Their patients actually are basically, they're almost like their kids. And so they really want the best for their patients. They want the best care for their patients, and they want also the best outcome for their patients. And also, like many of us, we also want to be appreciated by their patients. So in other words, if those patients are sent to us, if we do a really good job, it makes them look good. And so they really want to look good. They want to make sure that we do a good job for their patients. Next slide. So as I mentioned, primary care doctors are very, very busy. So you really want to lower the barriers and make it easy to refer those patients to them. So what I do is I actually get their cell phone numbers. and I give them my cell phone number. So I just text them and say, you know, hi, this is my cell phone number. In case you need my help, just feel free to text me. And so many of the primary care doctors actually will text me in the middle of the day and say, you know, I've got this patient, can you fit them in? And I'll text them back and say, sure. And that really sort of lowers the barriers for their referring patients to me. So I give them my office number, my cell phone number. I also have a back line, and I'm not sure how many of you have a back line, but if you don't have one, I'm sure that, you know, your practice will give you and share the backline number with you. I also give them my email address. And with this frequent communication, it makes it really easy, and they get, you know, to communicate with you. And the more I text them, they text me back, the easier it is. They won't feel stupid, or they won't feel that they're imposing if they quickly drop you a text and say, hey, I need a patient to see you. Can you fit them in? Next slide. So, obviously you've lowered the barriers, and now you're going to make it really easy for the patient to come see you. You take really good care of their patients by fitting them in. What happens next? Some of these doctors really want to know about what happened to the patient. In fact, sometimes some of my referring doctors will actually call their patient first. And when I call the doctor to fill them in about the patient, they'll say, oh, I already heard from your patient. So those patients already have given the primary care doctor feedback already. And so we really actually, as dermatologists, we really underestimate the close connection between some of these primary care doctors and their patients, and how much they really, really care about their patients. What's also really important is to thank these doctors for their referral. And very frequently, I'll just say, even though they might have been referring to me for many, many years, I'd say, thank you so much again for referring to me. I really appreciated that. Then one thing that I've been doing more recently, especially since I've been doing a little general derm, is I love to educate my referring provider. And what I've enjoyed doing is going to Visual DX, and I'll make a copy of the link. There's actually a little share button, and it copies that link, and then I'll send it either in the actual follow-up letter, or I'll text it to the patient, to the doctor, or I'll email them. And sometimes I'll even will copy a journal article and send it to them, because by empowering those referring providers, they actually sort of feel better about knowing more about that condition. And then also when the patient comes back to see them, they feel also better because they know more and they can talk with that patient more about their knowledge of the condition. And so in the patient's eyes, the primary care doctor also looks good. So I know that I was allocated to talk for 10 minutes, but I really thought I could really put it all together in 5 minutes. And I'm also very happy to share with you how I do those links for Visual DX. And also, if anybody else wants some tips, please feel free to drop me a line. Thank you
so much. Those are great, great tips. And I think you guys that have Epic, it's relatively a lower barrier to contact the PCPs. I think for those of us who don't share an EMR with the folks who refer to us, I really want to encourage everyone to actually get to know or get to have the email of the hospital that you are affiliated with, as well as some sort of remote login that can link you with those systems. So for me, for example, at Mystic Valley, I have a Melrose Wakefield email that I log on to and I can communicate with those PCPs. I also have a Winchester email that I communicate with folks. And it really lets them know who I am. And actually, I also have an out of office there that tells them if they send me an email, it should go directly to my AP Derm email. So there are many different things that we can do to ensure that we're still keeping up with our PCPs, because we've realized that they're our lifeblood, and we can't just expect the patients to show up at the door.
Those are great points. And I also wanted to add, for many of us who are attached to Lowell General Hospital, they have, well, I'm not sure if they're phasing it out, but they have this Tiger Connect. It's basically an app on the iPhone. It allows doctors to talk confidentially to each other. And it's only for those attached to Lowell General. And I think they might be switching to something else. But very often, the IT department of each of your hospitals will be able to share with you the ways in which some of the doctors can communicate. So this is Tiger Connect. I think it's still working, but if any of you who belong to Lowell General, maybe at the Westford office as well, it would be great for you to use that, because that's a great way of building relationships as well. And I've connected with some PCPs through that app for iPhones and Androids.
Thank you so much. So we're going to move on. I think we have just a couple more things. So we have some clinical operations updates. And then we do have a representative who's going to speak to us about Opzelura, which is the first JAK, topical JAK inhibitor. And I know many of you have questions about that. So just a few clinical operations updates, if we go to the next slide. So the first one is that MIPS 2022 is here. Remember that this is an opportunity to get 9% above your Medicare reimbursement rates 2 years from now, so in 2024. You all should have received an email about the information session on Friday, January 28th. So definitely please attend, and please take it more seriously. As COVID eventually fades away, MIPS is gonna keep rearing its ugly or nice head. So definitely keep that at your at the front of mind. Just wanted again to reiterate APOTHCO initiatives. So as you know, just because of staffing issues and because actually patients really love it, we are asking you to send your non-biologic prescriptions that are likely to need a prior authorization directly to APOTHCO. We have tear-offs that we can send to your office to really help that conversation, so your MAs really do it even before you do it. Yes, there's a slight conflict of interest in that we have a mutual funder, I guess. I don't know who how you call it, but AP-Derm receives no direct benefit from APOTHCO, apart from, I guess, savings from the fact that we don't have to spend a lot of resources with the PAs. The MEM survey results, I think we have a slide on that, right? All right, so thank you all for the positive feedback. We really took that information, as you can see, we use that information to actually give to the speakers who we asked to talk to us. So it's really relevant that you tell us what you're looking for at the medical education meetings. We had some top speaker requests that we're currently looking for folks who can speak on that. If you know anyone on any of these 7 topics, what's new in dermatology, biologics, billing and coding, genital dermatoses, medical economics, skin cancer, let us know so we can try to bring those people in. For the meeting format, we had about a split group. So some people wanted us to, many people wanted us to continue to do the virtual meetings, especially during the pandemic. And some people wanted us to start attending meetings in person, but the strongest preference was really for quarterly meetings rather than monthly meetings that we used to have in 2019 and early 2020. But what we're going to do going forward, because as you can see, we're really trying to do this to make sure that it remains a very strong value proposition to the clinicians who join AP-Derm, and also as a way for us to talk about all the changes and improvements that we're making to our practice. We really want to form a medical education meeting planning committee to plan the list of topics and presenters for this year. It's a great way to get engaged and understand what we're doing and what we're showcasing. We're thinking this is a really minimal time commitment, 90 minutes, maybe 1 to 2 times a year. We're hoping to have a first meeting next month. So please contact Heather if you would like to be part of this. We really want as much participation as possible because this is a group practice. Next slide. So the other thing we wanted to speak about, and this is highly relevant for everyone practicing. So we have realized that through the process, through COVID, there are opportunities that we haven't yet capitalized on in terms of getting to know all the clinicians and really building the practice that the clinician wants. So this is not necessarily saying, here's what the practice goals are, but really building it from the ground up and going to each and every one of you and saying, how would you like to see patients? And are we meeting your expectations? Are we doing everything that we need to do to ensure that your practice is what you would like your practice to be? And this means, do you feel like you're seeing the amount of patients in a day that you want to see? Do you feel like you're working the right amount of days a week, the right amount of hours a day? are you making enough? You know, as time has gone on and as you all have realized, CMS is cutting the revenue, the Blue Cross Blue Shield modified 25 cuts happen. There are so many things going on, and I think some people may start getting a little bit more concerned about things like that. Do you feel like there are things that we can do? You know, and MA training is absolutely on all our minds, so that's actually been addressed. But are there other things that can be done to ensure that we're getting you the practice that you signed up for and you would like? So there are going to be one-on-one meetings that the senior leadership team is going to be having with every clinician in the next couple of weeks to talk about your 2022 goals. And then we're really going to build the budget from the ground up. You know, how much support do you feel you need? And let's just make sure that we bake into the budget what support we need. And then there's going to be ongoing check-in with the with everyone. So more to come on this. This is just a very, very general conversation, and we're going to start this going forward. Next slide.
Toby, before we move on, if I could just add, Sharad and I spoke today about this. I'll be sending an email to all of our clinicians following the meeting to solicit your time and availability. We're hoping to get these done in the next week to 10 days or so. It's actually a pretty quick turnaround, but no more than 30-minute call. And the team is willing to make themselves available during the day, in the evening, on the weekends, whatever works best for folks to be as supportive as possible.
Thank you so much, Heather. All right, next slide. All right, and our next meeting is going to be with Dr. Cohen. He actually is near and dear to my heart and my brain, definitely trained me and got me to like patch testing. He is such a dynamic speaker, if any of you have ever heard him speak, and he's basically the international contact dermatitis expert. So we're really lucky to have him speak with us next week about contact dermatitis and patch testing, especially as we try to grow that in our practice. And so with that, I'm going to turn it over to Kara, who is our Opzelura representative, and she's just going to be speaking with us about the clinical trials that led to the approval, as well as the clearance or the current support, I believe, that insurance can give, or that they can give for insurance coverage. Thank you, Kara.
You're welcome. Nice to meet everyone. I know that some of you probably do recognize me because I am the rep in the Boston area and some of the surrounding cities. So you can feel free to ask me questions. I'm going to put my email address in the chat. And if we end up not getting to a question, either myself or the rep from your assigned region will definitely get back to you. What I would like to do is share my screen so you guys can try to follow along and see. Let's see if we can do this. Here we go. Can you see that how it says itch, scratch, inflammation?
Yes.
Okay, so this is really exciting. So I know that you guys have probably all heard buzz about it, and I apologize if I'm repeating myself to the people that I called on, but Opzelura has been approved. It got approved in the end of September. It's really nice because this is a cream and it's first in class. So we were the first ones to launch it. It looks just like this. So it's a 60-gram tube. It's a good size. It's cosmetically elegant. I always like to show my providers that it's a little cream and it doesn't have any burning, any stinging. I'll get into the details on it, but patients are going to enjoy how this feels. So Opzelura is indicated for the topical short-term and non-continuous treatment of your mild to moderate patients who have AD and they are 12 years in age and older. So that is what we have looked at. When we go into our mechanism of action, you can see that just like your other products out there for AD, we're targeting the source of itch and inflammation. So hallmark symptoms of AD, itch and inflammation, but we target IL-4, IL-13, IL-31 and TSLP. So some of the newer ones I like to point out are 31 and TSLP because those are your itch pathways. So it's a little bit different than some of our competitors. So we're going to have more of a robust patient type that we're able to have this product have success for. But just like you're familiar, with the itch scratch cycle, Dr. Zerwas likes to say, which is kind of an interesting analogy, that there used to be a lot of house parties going on, and then Opsilora came to the party, and now the party has parents and it's getting broken up. So not as many people are going in because we're really not allowing the same number of cytokines to just kind of run rampant all the way to the nucleus. We're really acting as like a traffic cop. So that's really exciting. And for our efficacy, because this is what people want to know, but I will show for our trial overview, we were studied as monotherapy. So this product's really nice because there was a washout period. So patients were not on any other steroid. They had to leave their skin raw for about 8 months. So they had to use Opsilora alone. And we studied 1,249 adult and adolescent patients in 2 identically designed double-blind randomized vehicle-controlled trials. We studied BID 8 weeks, twice a day. The affected BSA was 3 to 20%. They're 12 years in age and older. Their IGA score was a 2 or 3, and they've been suffering for at least 2 years. I love showing in the baseline characteristics because I'm sure some of you are thinking, how am I going to use this? 39% of patients had facial involvement at baseline. So this product really shines for those patients that are struggling with AD on their eyelids or even on their hands, on their groin. It works in sensitive skin areas, which is really nice. So when we look at our skin clearance results, you can see our primary endpoint was clear or almost clear skin. So the IGA treatment success at week 8 was 53.8%. Even at week 4, we had 46.6% of patients. So if your patient has a 2 or a 3, they can move down to a 0 or 1. So your patient could potentially move to clear skin in a short amount of time, which is really nice. And then itch is a huge problem with AD, as you all are aware. Our itch data is really, really remarkable. So we had at least a 4-point improvement in itch NRS at week 8, and that was on a 0 to 10 scale. So at week 8, 52.2% of patients achieved a clinically meaningful improvement. Even at week 4, 51.6% of patients were achieving this. And the itch NRS response was seen as early as day 3. And then when you move to change from baseline, you can even see that patients reported change in itch NRS score observed as early as day 1. And it's sustained through day 56, which is really great. So if you were to prescribe this product, Opsilora, on a Monday, your patient's going to feel relief on Tuesday for their itch. So that's really exciting because unfortunately that itch can be really, it can be really bad. So this is where our product really does showcase itself. I will point out the safety because it has to be addressed. We have the boxed warning, which I'm sure some of you saw who I've given PIs to or your other reps have. I will say, yes, we have that box warning, but it is a class warning. It's not for our product. I can honestly say, and we have an MSL who can talk to you in more depth about it, that we didn't have incidences of DVTs or thrombosis or serious infections, but we are in the same class of topicals. So the FDA did give us this, but we have so minimal systemic absorption that you could use this product to the fullest of its capacities and overuse it and still have less systemic absorption than an oral, even the oral ruxolitinib, which some providers do use right now. And when you look at our safety profile, it's nice to look at the adverse reactions because that is very real world and what is reported. Our number 1 adverse reaction is your nasopharyngitis at 3%. The rest of them are all 1%. So your patients are having AD, which means they could have allergies. That could be what the nasopharyngitis is. And I've picked that up from providers telling me that. It's a very safe and clean profile. And if you look at my cursor right here where I'm highlighting, there was such a low rate of application site reactions of stinging and burning that patients didn't actually even have to discontinue, and we didn't have to include it on our chart. So like I was mentioning, it's okay to put on the eyes. And that can be sometimes a very tough area to treat, or the hands. So when I am showing how to dose this product too, it is studied twice daily. No more than 20% BSA is how we looked at it. The patient would not exceed one of these tubes in a week. There's a lot of product in here and they only need a thin amount. It will last them, and it will be applied directly to the AD lesion, which is really great because sometimes you want to just target exactly where the patient is having that flare. So there's a place in the market for this. And when our company decides to identify patients, we looked at your uncontrolled itch. So someone who has pruritus and they don't have a lot of relief, they're going to get relief, and very quickly. So you'll be really happy because you'll get less callbacks. The sensitive skin areas, like I mentioned, really nice to have a product that doesn't burn in those areas. A patient who has persistent AD, so maybe they have failed on other things and they just didn't work, this is a really great product for that. They're reluctant towards systemics, or maybe their BSA is small and they don't need something like Dupixent because it's just on one small area. And then your adolescents, which kind of ties in with the compliance of using something like Protopic can sometimes burn. So this is nice to have patients knowing I'm not going to burn on this product. And then I always will show the best part, our savings. I know you all want to know, what does it cost and how can I get it? I heard you mentioned, I mean, I don't want to butcher your last name, Dr. O.B. Help me out. Okay, go. So we partner with Apotheco too. Patients can get it for $10 as long as they're commercially insured patients. So covered $10, not covered $10. They will do the prior authorization because we do want to see if it's not covered. We want to know the reason why it's not covered. This helps us as a company build better coverage, but we just picked up Blue Cross Blue Shield. We have coverage with Harvard Pilgrim. We have coverage with Tufts. So most of your patients probably have already failed on something, making this even easier to get filled. But say you decide, you know what, I want to go right for Opzelura first line, you can write it to Apotheco and do that. And as of right now, they are able to honor our copay card for those patients for $10. So it's affordable for your patients, I'd like to think, that are commercial, as long as they're 12 years and older. If they're under 12, even with a PA, unfortunately, it's not going through. And coming down the line, we will have 52 weeks of data, which is exciting to have. And we are set for a second indication towards the end of April for vitiligo. So we can look forward to that coming out because we're all getting trained in May on it. So we have exciting things down.
Thank you so much, Kara. I really appreciate it. You know, we have a couple of comments. We only have 1 minute. So if you have 30 seconds to answer. So the first comment is it's just a comment, but basically concerned about risk due to squamous cell cancer. And then the second comment was there's a cash cost of $2,000 for cash paying patients on GoodRx. So if there was a patient without commercial insurance, how much would it be?
So you would
To
have
Apotheco.
insurance. So are we talking like just Medicaid insurance or not?
Sure. Yeah. Let's go with all scenarios. So patient without insurance at all, patient with Medicaid or Medicare, and then we already talked about commercial insurance.
Okay. So Insight Cares is a hub that we have. It's our companies, and that is for all patients that have no insurance or they're on Medicaid. And if they are making under $55,000 a year as a single person, it'll be $0. Now, if it's a family and the family is making under $67,000, it's $0. If I'm your rep, reach out to me. If not, tell me what providers and offices want this. We have packets so we can make sure that everyone gets it. It's a form and you would fill it out and the doctor would sign it, the patient would sign it, and they are going to run a check on the patient's, like how much they make, their income. And if they meet the criteria, it's a fat 0 for them. Now your Medicare, since we don't have amazing coverage, the prices can change depending upon where they've spent money throughout the year. So keep checking in because sometimes the price can go down based on what they've spent. on other products, but also if they're in that same gap of the 55,000 or the 67,000 and under, they qualify for Insight Cares 2 for $0. So we're creating options to help your patients get this product. As for the question we talked about with cancer, that's an MSL question. So if someone could tell me who the provider is, I will make sure that the MSL gets in touch and answers you exactly what you want to hear, because they make me speak very on label and commercial.
The person did not state who they were. So,
Okay.
but thank you all
I'll
so
give
much. This was thank you so much, Kara. I think, we can definitely get your information. If anyone wants Kara's information, please definitely reach out to myself or to Heather. Thank you so much to all. Thank you to Heather for putting this together while I was running around and virtually trying to make it to the meeting. Thanks, Mark. And we look forward to seeing everyone for the patch testing conversation and presentation next month.
Thank you, everyone.
Bye.
Bye.